Thank you, sir, for your kind introduction. And I will now jumpstart the topic because I think it's a tough task, taking you through entire gamut of breast imaging in 15 minutes. I will try my best. So whenever there is breast cancer, what does the surgeon want to know? That is the job of the radiologist, to give answers to all these questions. Firstly, is there cancer? So I will just go through all these questions one by one. So for is there cancer in the breast, we need to, of course, do imaging, and mammography remains the primary imaging modality for breast. Ultrasound has a very good adjunctive role. MRI in selected cases. There are recent advances which add value to these investigations in particular scenarios. But mammography has definite limitations. It is not perfect. 15% false negative is well known. The sensitivity drops in women with dense breasts. I'm so sorry, we seem to be on different pages. Yeah. So the sensitivity drops in women with dense breast, as in this, the first case, you can see the fatty breast showing a small tumor, whereas even a large tumor is hidden in the next dense breast, which is only picked up on ultrasound. So for this tissue superimposition, which is the villain in mammography, firstly, the mammogram should be of a high quality. We should only accept good images. And even then, in dense breast, sometimes we cannot make out the pathology. Or, on the other hand, there is no pathology and we get a mimic of pathology because of superimposition. So the new kid on the block is tomosynthesis, wherein you can, instead of a single 2D image, what you get is a stack of images, like in the CT scan. And they are actually 1 millimeter sections through the breast, and you can scroll through them and hopefully unravel the structures within the breast. So how does it work? It is a little bit like CT scan, where the detector goes all around the body. Herein, it goes in an arc. So there is movement of the tube when there is exposure. So what you get is a series of low-dose images, and which are then reconstructed into a volume set, and you can see 1 mm slices. The total dose of tomosynthesis is approximately the same as the 2D digital mammogram. So together, that will be twice the dose. There's an example here wherein it is hard to see the cancer in the first mammogram. I'm sorry, the laser pointer doesn't work on this LED screen. The first one is a conventional image, which is not showing the cancer very well, shown by the arrow, but which could be seen very well on tomosynthesis image, along with its characteristic speculations. Breast ultrasound has indications, especially in women less than 30 years. It should be the first investigation, and in women during pregnancy or lactation. Otherwise, it can be used to assess a mammographic abnormality, for breast inflammation, and of course to guide the needles for biopsy or localization. Breast MRI is now very well established because of the standardized protocols that we use, because the dedicated breast coils we use, and now there is enough literature available on its value. The sensitivity is very high, but we must remember the specificity is moderate. So there are a whole lot of current indications of MRI, some very well established, some controversial. But the bottom line to remember is that the technical requirements must be met. We should only send patients for MRI if a MRI center meets these technical requirements. That is, it should be a minimum of 1.5 Tesla magnet. They must employ the gadolinium injection. Non-contrast breast CT has no role, breast MRI has no whatsoever. They should have a dedicated bilateral breast coil, which looks like this. A lot of times we get MRI breast done on body coils, which is completely unacceptable, and it cannot be read. There should be good fat suppression, and high resolution, good 3D gradient echo pulse sequences must be used to conduct a breast MRI. And this is what a breast MRI looks like. And after all this imaging, what does the radiologist do? He gives a assessment category to the abnormality or to the breast which is being investigated, and what indicates the suspicion the radiologist has of malignancy based on the imaging: mammography, ultrasound, MRI. So 0 is incomplete. 0 means that the investigation is still incomplete. You need to do further tests, or you want to get the prior studies. Negative and benign means there is no cancer. BIRADS 3 means that it's probably a benign finding and the chance of malignancy is less than 2%. So in this category, there are two options. You could do a follow-up, do a repeat imaging, and which could be at an interval of 6 months, and prove that there is no increase in the size of the finding, and then ultimately label it BIRADS 2 at the end of 2 years. The other option is to biopsy even these BIRADS 3 lesions when there is anxiety on the part of the patient, on the part of the clinician, or you are not sure that the patient is going to return for follow-up. It is better to biopsy these lesions even if they are BIRADS 3. That is, the suspicion of malignancy is less than 2%. BIRADS 4 and 5 lesions warrant biopsy. BIRADS 5 is classical signs of malignancy, that is malignant unless proven otherwise. So it is more than 95% chance of malignancy. So that means that once a BIRADS 5 suspicion has been placed on a lesion, even if the biopsy comes as negative, benign, we do not accept that result. We think it is not concordant, and it is better to go for a repeat biopsy with a thicker needle, or do a surgical excision. Now, after all these imaging modalities, let me just put forth two very similar looking cases and say, is there cancer in the breast? So despite all our imaging modalities and our BIRADS, we are sometimes, or most of the times, not really able to say benign or malignant with great confidence, and we need to resort to the biopsy. So you can see that these are very similar looking lesions, but whereas the first one is a benign fibroadenoma, the second one is actually a high-grade triple-negative cancer. So we need to resort to biopsy because there is a significant overlap in the features. So how do we perform the biopsy? It should always be a core biopsy. A 14-gauge gun should be used. Also a vacuum-assisted biopsy, in which 8 to 12 gauge needle is used, and you take the help of vacuum to acquire more samples. The idea is to get as close as possible to excision biopsy. Now the type of imaging modality that you would use for guidance would depend on the case to case, which is the best modality showing the lesion and how comfortable you are with it. So most of the cases are done under ultrasound guidance. However, sometimes you need stereotactic biopsy for mammography-only findings, especially microcalcifications, or rarely MR-guided biopsy when you can't see a finding on ultrasound or mammo, even on second look, and it's a MR-only finding. Once cancer is confirmed in the breast, this is the treatment plan, and then what role does imaging have? Correct patient selection for the type of surgery is the key to good outcome, and therein comes the role of radiologist. You need to tell exactly what is the size of the tumor, where is it placed, is there multicentricity, axillary lymph nodes, are they involved? So firstly, the size should be accurately measured in 3 dimensions. The distance from the nipple or the pectoralis major should be communicated to the surgeon. You should make the best effort to see whether the cancer is solitary, multifocal, or multicentric. A case of multicentric cancer in this slide. And most of the times, and the local extent of the disease, one should remember that all microcalcifications must be taken into account for assessing the tumor burden. Ultrasound often leads to an underestimation. Most of the times, ultrasound plus mammography are able to show the additional lesions and they are sufficient. MRI is not required. But sometimes MRI is a must, and I really like these EUSOMA criteria for doing an MRI for extent of disease. They specify that if there is a discrepancy between the clinical examination, mammography, and ultrasound regarding the extent of disease, MRI should be performed. If the breast is too dense and the mammographic assessment cannot be made, if the patient underwent an incomplete surgery outside and the margin status is positive or unknown, MRI remains the choicest modality. Or if BCS is being considered for an invasive lobular cancer, since it has a high risk of multicentricity as well as bilaterality. This is an example wherein a lady had a single lesion on mammography as well as ultrasound, but the MRI showed 2 lesions which are quite at a distance from each other. Another patient where mammography and ultrasound are not very good in assessing the complete extent, but the MRI is beautifully showing us the extent of disease. Now, are the axillary nodes involved? In clinically node-negative patients, we must do a dedicated, good quality, high-resolution axillary ultrasound because ultrasound is very sensitive to detect suspicious lymph nodes, provided you follow a meticulous technique. So this is how we should translate the diagram of level 1, 2, 3 nodes onto the patient and carefully look at all the lymph nodes. A normal lymph node is thin with a large fatty hilum, and the cortex is quite thin and regular. The abnormal findings in suspicious lymph nodes may be just a focal cortical thickening, a diffuse cortical thickening, still maintaining the hilum, or finally the node becomes a rounded mass with loss of fatty hilum. So what about non-palpable breast cancers? How are those going to be dealt with? Herein we need wire localization. Like in this case, this small non-palpable cancer has been wire localized, and then a conservative procedure could be performed. This guidance can be with MRI, mammography, or ultrasound. This is the wire localization hardware which we use with mammography. This is the way we do it with ultrasound. This is ultrasound-guided wire localization. Radioactive seed localization can be performed because some of the surgeons really don't like the wire, and also the need to schedule the patient just before the surgery. So radioactive seeds can be put instead of the wire by up to 1 week before the surgery. A very useful method we have found is intraoperative ultrasound guidance. So in this, the ultrasound probe, well covered with a sterile sleeve, is applied through the wound during the surgery to guide the surgeon in real time about the margins and location of the lesion, and you end up with a specimen which can, again, you can check the margins there and then in the operation theater. Lastly, when we are giving neoadjuvant chemotherapy, is it working? So MRI is better than palpation or mammo or ultrasound, and which MRI criteria is the best is the volume. So when you look at the volume of the tumor, it shows an early change which is not perceivable on palpation or on mammography. So reduction in volume is the most sensitive marker of response. And to conclude, I would say that breast imaging is special because breast radiologist is using the imaging in its entire bandwidth. And breast imaging was the first specialty where standardized wording and reporting was developed to ensure that our messages are clear and unambiguously taken. And in fact, this is now being followed in the other radiology specialties also. And breast radiologist always has to be a comprehensive radiologist, there wherein from diagnosis to imaging, from diagnosis to helping the surgeon in excision, the radiologist has a role. Thank you.